everyone, and a very warm welcome to another episode of MedSynapse podcast series. I'm your host, Haley, and today we're diving into a topic that many of us encounter almost daily in fertility practice, yet one that continues to raise difficult questions and clinical dilemmas: diminished ovarian reserve. Despite advances in stimulation protocols, adjuvant therapies, and newer interventions like PRP, outcomes remain unpredictable. So the real question is what actually works. And to help us unpack this with clarity and clinical insight, we're delighted to be joined by Dr. Navdeep Singh Pannu, a consultant obstetrician, gynaecologist, fertility specialist, and laparoscopic surgeon at Alpha IVF in Kuala Lumpur, Malaysia. Dr. Navdeep brings not only extensive expertise in assisted reproduction, but also a deep understanding of the emotional and biological complexities couples face on their fertility journey. So, Doctor, it is such a pleasure to have you with us today and welcome to the show.
Thank you very much for inviting me to this podcast. It's an honor to be here today.
Yeah. So, Doctor, just to begin with and to set the stage, what exactly is diminished ovarian reserve and why does it remain one of the most challenging conditions to treat in reproductive medicine?
Well, diminished ovarian reserve, short form is like DOR. So it refers to the reduced quantity and often quality also of oocytes relative to age. So clinically, we define it by using something called the anti-Mullerian hormone, low AMH, or even by ultrasound scans, low antral follicle counts, or just poor response to stimulation. And we usually follow the Bologna or Poseidon frameworks in terms of our definition. So there are significant heterogeneity in terms of definitions. So it makes doing research papers or even data collection a little bit more challenging when you want to combine all the data, because some centers have a different definition. But generally, it's along the Bologna and Poseidon frameworks. So this heterogeneity matters because this diminished ovarian reserve is not one disease or a separate individual kind of disease. However, it's a whole spectrum of it. The reason why I say that because a patient who is 32-year-old with low AMH is biologically very different compared to a patient who is 42 years old with the same AMH. And this also influences the eventual adjuvants that we use or when treatment options that we use, and which one can work and eventually don't. So what makes it very challenging is that we know for sure we cannot increase the number of primordial follicles. Okay, and most interventions we have right now generally attempt to do either optimize the recruitment of the remaining follicles or improve the oocyte competence. So there are many used treatments which we have, and some are biologically possible, but some are effective, but some are just not working at all. So there are a lot of randomized trials we have now which actually dwells into all these options.
Yeah, so I think that's such an important clarification that everybody needs to hear about DOR. So thank you for sharing that, Doctor. So now, Doctor, what was your main objective behind choosing this topic and why is it especially important for day-to-day IVF practice?
Well, generally, I want to discuss what therapeutic interventions that can truly improve IVF outcomes in women with low ovarian reserve. This is important because the DOR patients are often exposed to high gonadotropin doses or even multiple add-ons which some don't work. And eventually, they will have a lot of emotional and even financial burden which they have to go through. So that's why I feel this topic is very important to be discussed.
I think that's like a key takeaway, and I think DOR isn't like rare or niche anymore. Just correct me if I'm wrong.
Yeah, it's quite common. It's commoner than what we think it is.
Yeah. And there's often a reflex to increase gonadotropin doses in a DOR patients. So do higher doses to improve outcomes, or are we just overestimating their benefit?
Well, increasing the gonadotropin, like FSH doses, does not significantly improve live birth rate or pregnancy rates in women with diminished ovarian reserve. While higher doses may slightly increase the number of retrieved oocytes, but this generally does not translate into better reproductive outcome. So basically, this whole idea supports the concept of a ceiling effect, where once recruitable follicles are maximally stimulated, more FSH add-ons may just increase the cost without the benefit to the patient. So recently, there is a shift towards mild or even individualized stimulation rather than aggressive dosing, especially in the older DOR patients. So we tend to try to reduce the doses and to what they need. And how we determine the doses, basically, one, we review their previous notes about how much of medication they used previously. Then we can modify it accordingly. And the other thing is number of follicles or even the anti-Mullerian hormone levels.
Correct. I think also more medication doesn't always mean like better biology. That's like important for clinicians also to understand. I think patients as well. So now, Doctor, in your experience, is there any stimulation protocol that truly stands out as a superior for women with diminished ovarian reserve?
There is no single stimulation protocol, whether antagonist, agonist flare, or mild stimulation. None of it is superior in terms of the eventual outcome we want, the live birth rate. So, now what some data suggests recently is that instead of a protocol choice, okay, I think we should look at the biology of the patient, which is basically follows it aligns to the Poseidon philosophy, where treatment should aim to maximize the probability of obtaining at least one euploid embryo, rather than focusing on a protocol which is one size fits all. So in practice, this supports protocol individualization or personalization of treatment. And some use HMGs and other use recombinant, and the outcome is basically similar. The other medications I like to highlight is the LH luteinizing hormone. Now, it's said that LH supports androgen production at T cells, so indirectly enhancing follicular responsiveness. But then again, some data have said no clear benefit. Some have said there are benefits. But I guess in medicine right now, when we are at the end of the road where we do not know how else to help, we generally prefer a more multimodal or multi-medications. So we tend to mix FSH and LH all together. But from data, not much of evidence that shows a benefit. But generally, we prefer to give it to the hypo patients or hypo-LH environments. Okay, and that generally, like advanced maternal age or even profound DOR, really very low. So in those kind of patients, we generally do give LH. But basically, I think the key message here that LH may not be for everyone, but it can help some patients. And it might be beneficial to monitor their LH levels midway during the stimulation to see whether or not they need it or not.
I think that's insightful, and I also feel that as you also mentioned, the LH doses also depends on your individual needs, right?
Yes.
So now, doctor, let's talk about adjuvants like androgens, DHEA, growth hormone. So do these interventions genuinely help, or is it the evidence that is still evolving?
We talk about androgen pre-treatment, for example, the DHEA or testosterone. There have been some improvement in the responsiveness of the stimulation protocols, but there are a lot of evidence out there which is heterogeneous and low to moderate quality and a lot of mixed findings. The other things is like when growth hormones, for example, that too shows very inconsistent results. So there's not much of improvement too. But I would say the key takeaway is that this and some of the adjuvants like DHEA, testosterone may benefit some subgroups, but I don't think it should be routinely used. And importantly, I guess when you want to start something which is not really evidence-based, then it's important to talk to the patient clearly and, counsel the patients about what you're going to give it and why you plan to give it to them.
I think that's like a balanced perspective, and communication with the patient here is the key.
Yes, definitely.
So now, Doctor, what's the biological rationale behind using androgens in women with diminished ovarian reserve?
Androgens are said to upregulate the FSH receptor expression on the granulosa cells and enhance early follicular growth. So when you look at in these patients, they generally have a reduced androgens, okay, so which eventually will impair the sensitivity to FSH. So adding testosterone or when the DHEA, they will increase their intraovarian androgens, which will help in their responsiveness. Okay, so basically this provides a rationale where testosterone, even DHEA, is used for pre-treatment. Basically, a lot of them will call it pre-treatment or priming the follicles before stimulation, and rather than just increasing the FSH by itself. So they start the androgens before, and then they start the stimulation.
Mhm. And I think that explanation really helps clinicians understand why androgens might work for the women especially. So thank you for highlighting that, doctor. So now, doctor, what does the current evidence tell us that about testosterone pre-treatment in DOR patients?
Testosterone pre-treatment have shown some improvement in some studies, and but inconsistent in terms of the live birth rate. As I mentioned earlier, the androgen itself helps to improve responsiveness. But the problem is all these studies have they are small sample size, and there's variable dosing and duration, how long to give it to them, and inconsistent patient selection in some studies. So we don't know whether actually it really works or not. But a lot of centers tend to use at least about 12.5 milligram to up to about 15 milligram per day between 10 to 21 days prior to stimulation. And if I were to use it, I generally prefer to use 12.5 milligram at least about 3 weeks prior to the stimulation in this age group, or rather in these DOR patients.
Like it's less about blanket use and more about patient selection and timing.
Yes.
So now, doctor, how does DHEA differ from testosterone in this context, and does it truly deliver a clinical benefit?
Generally, DHEA is a proandrogen, so it converts locally to testosterone and estradiol within the ovary itself. So clinically, when you talk about DHEA and testosterone to patients, to women, they don't mind DHEA, but a lot of them feel a bit worried taking testosterone, and so I guess DHEA is more acceptable for long-term priming, like 6 to 8 weeks, and but then again, you should counsel the patient and tell them what clear, realistic expectation. The doses do tend to vary between 50 to 75 to 100 milligrams. And how long? Generally, I do give DHA to my patients, especially those older patients or those that diminished ovarian reserve. I tend to give about 75 milligram per day, usually 25 milligram 3 times a day, at least 6 weeks prior to the IVF.
Mm. So now, doctor, growth hormone is another debated add-on here. So how does and what does the evidence actually say about its role in DOR?
So, growth hormone is thought to improve oocyte mitochondrial function and the follicular microenvironment. But then again, there's not much of robust research and studies. And given the cost and the injection burden, so it should not be used empirically and should choose which patient you like to use it to. And I generally, you also use growth hormone to some patients where we can start it before the stimulation. So as a pre-treatment or priming. So there is no actual protocol or there are no actual doses and ways how to give the growth hormone. So some give it during the stimulation, some before, So generally what I prefer doing is that I prefer to start it at least 2 to 3 weeks before the stimulation cycle, and then let me start the stimulation. So then again, you call it the priming or pre-treatment. That's what I would prefer to do.
I think I appreciate that like evidence-based first approach is necessary here. So, Ladakar, ovarian PRP is gaining a lot of attention globally. So, what's your honest opinion on its role in managing DOR?
Well, all of us are looking for the magic treatment or magic pill to help these patients because all doctors mean well. They want to help the patient. So PRP is one method we have, which it has shown some benefit in some research, but some research they didn't show much. And yes, I also have attempted to do this in some of my patients, and similarly, I found some benefited, some didn't. So most importantly, it's easy to tell the patient about it because it's their own blood. So no risk of infection or allergic reaction or issues like injecting somebody else's, blood into them. So they're more acceptable to it. But while it is biologically appealing, it contains growth factors that, may influence ovarian environment. So basically, it causes angiogenesis. Angiogenesis is more blood supply growing around the tissue where you inject it inside. And then eventually more medication can be supplied to those areas. And but unfortunately, there are very small observational studies which talk about the PRP. So currently, it remains like more of an experimental, and I don't think it has come into normal conventional treatment yet. But I'm sure eventually, it may evolve into something more standard part of treatment, and some may even mix in PRP with exosomes of stem cells to improve the responsiveness of the ovary eventually to gonadotropins. But then again, well, I think we're still waiting for robust evidence-based studies. Till then, it's still more experimental and research-based.
Thank you, doctor, for sharing such a clear, grounded, and clinical practical discussion today. So, and as we wrap up today's session, let me tell you that your insights were quite helpful for me, especially knowing about this particular topic. So, thank you so much for sharing it with our audience as well, and I'm sure we'll take away a lot today. And your audience, remember, if your healthcare professional is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, keep questioning, keep learning, and keep putting patients first. Thank you.